Hello, good afternoon. I'm Marcy Ravitch. I'm the director of the Massachusetts Child Psychiatry Access Project, and I want to welcome you to the 7th in a series of clinical conversations that MCPAP is sponsoring the 4th Tuesday of each month from 12:15 to 1:15. Today's topic is identifying and managing autism spectrum disorder in pediatric primary care. We know this is a very popular topic and we had many requests for it, so we hope that this meets your needs. And just want to remind you that after the webinar there'll be a survey that pops up that you can let us know if it met your needs and help us to improve our future webinars. So we hope you'll take a moment to complete that. A couple other housekeeping items. This session will be recorded and the slide deck will be available on the MCPAP website at www.mcpap.org. It'll be on the website under Archive News and Webinars under the tab called About MCPAP. We're going to hold questions until the end of the session. There should be plenty of time for questions. If you could please type your questions into the chat box, that is the most efficient way for us to take and answer questions. And now I will, without further ado, introduce our presenters today. We have Dr. Donald Sherak, who's a child and adolescent and forensic psychiatrist and psychiatric consultant. Dr. Sherak received his undergraduate degree from New York University and medical degree from the State University of New York Health Sciences Center in Brooklyn, New York. Dr. Sherak completed his training in adult psychiatry at Kings County Hospital in Brooklyn and completed a fellowship in child and adolescent psychiatry at the Neuropsychiatric Institute of the University of California, Los Angeles. He is the former medical director of Whitney Academy, a residential treatment program for cognitively impaired, developmentally disabled adolescents and young adult males with severe behavioral problems and sexual misconduct. He's a consultant to the May Institute for Brain Injury and Related Disorders, a nationally recognized site for the treatment of children and adolescents with acquired brain injury. He also consults to the Center School for Crisis Intervention in Holyoke, Massachusetts, and lectures in the Department of Psychiatry at Tufts School of Medicine. We also have Dr. Tracy Mullare, who received her medical degree from Albany Medical College. Dr. Mullare completed her residency at the Brown Triple Board Program in Pediatric Psychiatry and Child Psychiatry. She's a clinical assistant professor at the Alpert Medical School of Brown University and instructor in psychiatry at Harvard Medical School. She's the assistant medical director of the McLean Southeast MCPAP and McLean Southeast Adolescent Acute Residential Treatment Program. Dr. Mullare is a psychiatric consultant on the MCPAP team at McLean Southeast as well. So I'll turn it over to the two of you. Thank you.
Thank you, Marcy. And for those of you that have been on previous MCPAP webinars, we wanted to bring it to your attention that the format of the webinar today will be a bit different in that the design today is a clinical conversation in an interview format. We decided that in order to cover the topic of autism spectrum disorders, it would be helpful to interview an expert in the field. In addition, the slides that accompany the lecture are in an outlined format that follow along with the interview. We really appreciate Dr. Sherak agreeing to help us today. Let's start the interview with a question about prevalence. There's so much media coverage about autism spectrum disorder, and it seems like we keep hearing about an increase in the prevalence of ASD. Can you briefly speak to the reason for this?
Well, back in the 1980s, and in fact in 1980, the CDC reported a prevalence of autism of 0.05%. And I was in training at the time, and it was like I'm learning about a rare condition. But in 2015, they found a prevalence of 1.5%, which represents a 30-fold increase. So are we in an epidemic? Is autism on the rise? Actually, with greater awareness of the diagnosis and the core clinical features, many children who were previously given other diagnoses are now being correctly diagnosed as having a condition on the autism spectrum. This recent change in diagnostic criteria, driven by the DSM5, plays a big role as well. The DSM5, the Diagnostic and Statistical Manuals, is the standard classification of mental disorders used by mental health professionals. The 5th edition was published in 2013, but it hadn't been even having a superficial revision in over a decade. Changes to the criteria that the DSM-5 combined 4 previously separate conditions into the autism spectrum disorder. And there's been a lot of resistance from some folks who wanted to identify their children as having the other conditions. So they were autistic disorder, Asperger's disorder, childhood disintegrator disorder, and pervasive developmental disorder, not otherwise specified. Their rationale was that there was a consensus that these 4 disorders were essentially indistinguishable in terms of clinical presentation and outcome, and that there were no clear boundaries. Rather, the symptoms existed across a spectrum of greater to lesser severity. But the core symptom features remain. One is impaired social communication and social interaction. 2, restricted repetitive patterns of behavior or interest. In addition, the cutoff requirement before age 3 was changed to onset in early developmental period. This criterion allows for diagnosis of autism spectrum disorders even when there was a history of symptoms that might not be currently present, acknowledging that there may have been symptom improvement through intervention or normal development. In addition, the DSM-5, a new disorder was created, social communication disorder, which is reserved for children with impairment in social communication and interaction, but without any of the restrictive repetitive behaviors that are part of autism spectrum. And sometimes you will see a rush to judgment that misdiagnoses kids who fall into that category.
Where do these children typically first present?
Well, primary care physicians, especially within the context of medical home, are the first point of contact where parents have concerns about their child's development or behavior or getting their child to comply. The challenging task is suspecting the ASD diagnosis as early as possible. Early detection and provision of services early improves long-term prognosis. And this has been shown through lots of excellent clinical work and creative work and research. This makes the early diagnosis particularly important.
Can you speak about what makes the early diagnosis so challenging?
The early diagnosis of ASD is challenging in the context of primary care visits because there is no pathognomonic or clear, unique identifying sign or laboratory test to detect it. It's not an etiological disorder such as trisomy 21 we still refer to as Down syndrome, so making the diagnosis more challenging. There's no known single biological marker either, or genetic marker that we can point to and say, this is the cause. So that's why the incorporation of standardized assessment screening tools into practice is so important. For example, the revised MCHAT, or the Modified Checklist for Autism in Toddlers. This is a 2-page parent report screening tool that parents could do and bring into the office that assesses risk for autism spectrum. It's available for free for clinical or research purposes and can be found at mchatscreen.com. The MCHAT can be administered and scored as part of a well-child care visit, and it can also be used by specialists who may be working with the child, for example, with OT or speech. In addition to be a highly effective screening tool, in addition to being a highly effective screening tool and to not miss potential cases, there is also a very high sensitivity. So in order to be that, so it's going to have some false positives for children who screen with it, but have other issues. So the attempt is to cast as broad a net as possible. So to address this, developers of the MCHAT have added up a second follow-up questionnaire which refines the diagnostic impression. The form and the scoring instructions can both be downloaded. The scoring can be done in under 2 minutes. This is consistent with the American Psychiatric Association's, the American Pediatric Association's recommendation that all children receive autism-specific screenings at both 18 and 24 months of age. If a positive screening occurs, more thorough assessment is warranted.
What are some of the symptoms you hear from parents that are red flags for an ASD diagnosis?
Well, when parents raise concerns about social skills problem, there's a serious red flag, and ASD should be considered. Failure to meet expected social skill development is a hallmark of ASD. Early social skill deficits may include failure to make or keep eye contact, not smiling in response to being smiled at, aloofness, failure to orient when their name is called, failure to use gestures to point or show, or failure to follow when you point or show, lack of interactive play, lack of interest in other children, as well as not responding to having their name called specifically by age 1. Combinations of language and social delays or regression in language from previous milestones being met or not meeting social milestones are even bigger red flags, and they should prompt immediate attention for evaluation.
What kind of symptoms of ASD do you easily elicit in your office visits?
Well, one of the key features of autism that is evident in an office visit is impairment in shared attention. An easy way to do this is when the child is looking at you, is to point at something and see if the child follows your finger. Most kids, even those with ADHD, will divert their attention long enough and will look at the item that you point to with you. So you go, hey, look at that funny, clown over there that you have sitting on your bookcase. So they'll do that with you. Kids with autism would not. This is one of the core social cognitive deficits that have with this impairment, which involves the capacity to take into perspective, to take in the perspective of another individual. In addition, you can call the child's name, and if he or she doesn't respond by age 1, then this is consistent with a possible diagnosis of autism. Kids with ADHD may not respond quickly, but they will respond. Autism spectrum disorder kids also do not join in play with or imitate other kids. For example, if you sing or clap, they tend to not join you as you clap or sing along. You can't engage them in that way, whereas other kids would be happy to get them going. Even something as simple as like, let's sing happy birthday together, all kids.
How can you pick up the language deficits in the office setting?
Language deficits are best elicited by developmental surveillance of language milestones. The first evidence is often not meeting speech development milestones, that is, using single words by 12 months of age, or having phrase speech by 36 months. If the autistic child has developed fluency in their speech and are using phrases, they may be using scripted or stereotypic phrases or using phrases inappropriately. Developmental surveillance during assessment needs to always include social emotional milestones in addition to the more traditional motor, cognitive, and language ones.
What other ASD symptoms do you see at different ages in your office?
Well, preschool children with autism typically present with marked lack of interest in others, failures in empathy, absent or severely delayed and constricted speech and communication, and marked resistance to change, rigidity in schedules and things like that, very restricted and often atypical interests, and stereotypic movements, the classical movements that we see sometimes. Common parental concerns in the office visits could include a child's lack of language, inconsistencies in the responsiveness, or concerns that the child actually might be deaf. Higher functioning, less impaired, and kids are more mildly symptomatic can be harder to diagnose. Children with autism and some social communication and communication skills usually increase by school age. However, problems dealing with change and transition will be apparent. There also may be various self-stim or self-injurious behaviors that become prominent during this time. Predictors of ultimate outcome include the presence of communicative speech by age 5, as well as the overall cognitive ability, the IQ. In adolescence, a small number of individuals with autism will make marked developmental gains, typically the higher functioning kids or folks who've been in a very enriched environment to work with them. Another group will actually behaviorally deteriorate and have more tantrums, self-injury, and aggression. Around this time, comorbid psychiatric conditions can also emerge. Typically, they involve unipolar or bipolar mood conditions and sometimes psychotic disorders as well.
What do you think about in terms of differential diagnosis when you are assessing these kids?
Well, developmental language disorders impact socialization and can be mistaken for ASD. The distinction is especially difficult in preschool children, but there are two behaviors that have responded consistently, have been reported consistently to differentiate autistic children from language-impaired children at 20 and 42 months of age, which are the pointing for interest and the use of conventional gestures. Children who come from an environment with severe neglect and social impoverishment may appear to be somewhat autistic because they're in a state of neglect, but when they're placed into a nurturing or stimulating environment, they begin to change and they differentiate from the ASD children. In childhood, there also can be comorbidity between ASD and attention deficit hyperactivity disorder. Severe ADHD with impulsive symptoms that impair social function severely can look like autism. The historical prohibition on making the additional comorbid diagnosis of ADHD in those with ASD has been removed in the DSM5. So if the conditions are comorbid, the symptoms may be less severe once the ADHD is effectively treated. Children with reactive attachment disorder may also exhibit inappropriate social responses, but these also usually improve substantially with consistent caretaking. Now, obsessive compulsive disorder has a later onset than ASD, and it's characterized by repetitive patterns of behaviors, but in OCD, these behaviors are dystonic or distressing to the child, and there can be an understanding so that there is a compulsion, there's an obsession, a cognitive obsession behind the compulsion. OCD is not typically associated also with social communication impairments. Symptoms that characterize anxiety disorders, such as excessive worry, the need for reassurance, and feelings of self-consciousness, can be seen in ASD, particularly in higher functioning ASD individuals. However, the two conditions can be differentiated by the prominent social and communicative impairments seen in ASD, but not in anxiety disorders, and the developed social insight that children with anxiety will have. Many features of anxiety, for example, severe anxiety and social phobia, can look like autism from a distance, but you need to look carefully for evidence of social engagement, social attention, eye contact, responding to name, and the reciprocal play we talked about before. Differentiating childhood schizophrenia from autism can be difficult because those children are characterized by social impairments and odd patterns of thinking. However, florid delusions and hallucinations are rarely seen in autism, and when they are, they're often transient.
Can you describe some common comorbidities you see with ASD?
There are multiple behavioral difficulties that can be observed with ASD, including hyperactivity, self-injury, aggression, stereotypical behaviors, obsessive-compulsive symptoms, and symptoms of affective disorders. The issue is whether these qualify as separate additional disorders is a complex question. Affective symptoms are frequently observed in ASD children, and they can include lability of mood, inappropriate affective responses, they're just incongruent, anxiety and depression. The impairments in emotional regulation processes can lead to under or overreactivity. Overt clinical depression is sometimes observed, and this may be particularly true for adolescents in the Asperger's end of the spectrum, what we used to call Asperger's, or the higher functioning autism spectrum disorder kids. And saying not just that someone has ASD, but whether it's mild, moderate, severe is really important because there's such a broad range. Now, the attentional difficulties are frequent in autism, and they reflect cognitive, language, and social problems. Again, the historical prohibition on making the additional diagnosis of ADHD in those with ASD has been removed in the DSM-5. I encourage people to do that for the obvious reasons. Now, sleep disturbances and seizure disorders occur at rates much higher than in the general population, and these should be looked for and dealt with also. Important to add that this diagnostic sword can cut both ways. I've seen a number of children over the years who suffered from very high anxiety or condition of fetal alcohol exposure, social language impairments, intellectual disability, or environmental neglect, or in some cases a combination of those, that the parents present as having an autism spectrum disorder when the key diagnostic features that we mentioned about play and attention earlier were clearly missing, even though the child still was substantially impaired.
After you're confident of the diagnosis of ASD, what are your next steps to support this child?
depending on the child's presentation, I would choose target symptoms, and it's really important to define these and guide or recommend referrals for treatments that include educational interventions, behavioral interventions, speech and language, or physical therapy, parental support and behavioral training, as well as sibling support and medications. Knowing the diagnosis and then assessing IQ and adaptive functioning with testing inform the educational plan with specific recommendations that can include speech and language therapy, social skills training, and counseling. The physician then is a bit of a team leader that the family then consults with. And having these target symptoms and being able to quantify them and really count, for example, the frequency and the intensity and severity of some of the target behaviors is a very important way of being able to judge when progress is or is not being made.
And what other kinds of functions are you providing as a team leader?
Well, to follow up on the last comment about how important it is to measure and count things, to be a team leader means that I'm following progress while the interventions are in place and making sure that the child is making gains. So it's important to quantify around the behavioral goals and looking at the frequency of intensity of things. For example, it could be tantrums, in which you want to know how often they occur, injury to others, or self-injury. If the school is behind in testing or if supports are not meeting the child's need, I may write a letter actually requesting that there's an updated IEP meeting or repeat academic or speech and language testing. I may need to reach out to the school counselor and advocate for the child if there's support's still lacking. And sometimes school systems vary tremendously in their sophistication, in their resources, in their willingness to work with kids. And I've seen some school systems that really pride themselves on carrying the child through and really take it on as a sort of take a village to raise a child sort of thing, and bring those supports and include the child, even though the child is functioning at a different level. In addition, families can need psychoed and guidance through the many and often overwhelming behavioral, educational, psychopharmacologic, and alternate treatment options that are available to them. Support groups also can be of help.
Can you mention the general areas you're following up on during each office visit?
Well, for all children, I'm going to follow up on the status of medical comorbidities that are also being followed by the primary care team, such as seizures, cardiac, renal, GI issues that impact the child's functioning and impact stress on the child and the family. Weight gain and other side effects of the second-generation antipsychotics that they're being used also warrant close monitoring as well. It's important to regularly screen for abnormal involuntary movements and also to track weight gain. It's not widely appreciated, actually, that studies have shown approximately 60% of all parents of children with autism spectrum disorders are also utilizing or have in the past utilized complementary and alternative treatments and giving them to their children. Most of these interventions are benign, but they're not always benign. So it's important to know what's going into your, into your patient. And sometimes parents have a lot of shame, or they feel that you're going to reject them if they tell you about this stuff. So being open to hearing about it and being non-judgmental if the things are not toxic and not interfering with the more evidence-based care is really important. For very young children, issues of diagnosis and identification of treatment programs often will be the most important things to focus on. For school-age children, psychopharmacologic and interpersonal behavioral issues typically become more prominent. I'll also follow up on educational issues. Is the child making the appropriate gains in school? And are the schools providing all of the contracted supports? What are the benchmarks of the IEP? Are these supports sufficient to meet the child's needs? I'll also follow up on any psychiatric comorbidities, as for example, ADHD, anxiety, irritability, and aggression. For adolescents, vocational and pre-vocational training and support, thoughtful planning for independence and self-sufficiency become important. The questions of sexual behavior and substance abuse can come up for higher functioning individuals. Monitoring and mastering self-exploratory, sexually self-stimulatory behaviors and doing it in appropriate ways and privacy can be an issue for higher functioning and for lower functioning individuals. As part of the long-term follow-up needs, parents and siblings of children with ASD will need support. I inquire as to how the family is functioning. You may have heard families only is functioning as well as its lowest functioning member, a truism I've heard many times over the years, and want to see how autism is impacting all the family members to determine if the family, in the larger sense, needs additional supports.
Could you discuss some of the general treatment strategies recommended for children with ASD?
Early management strategies can include the following. After an ASD diagnosis is made, the family should be provided with the current literature and information regarding parent support groups, intervention programs, and community services. Support group referrals should be offered. National and regional parent support organizations such as the Autism Society of America can be a benefit and a source of information and really help families get on the path and start making progress and deal with the issues. For children younger than 3 years of age, early intervention is recommended. Interventions can include behavioral methods, early developmental education, communication, occupational and physical therapies, highly structured social play interventions, and extensive behavioral parent training. For children older than 3 years of age, school-based special education is recommended. Programs should provide children with structure and methods that will enhance their social skills, their functional communication, and learning. Speech and OT are typically included in these programs. Another early management strategy is behavior management. Behavioral training, which includes communication development, has been shown to be effective in reducing problem behaviors and improve adaptation. The overall goal of the approach is to reinforce desirable behaviors and to reduce undesirable ones using behavioral psychology theory. And some of this is sort of counterintuitive, and getting parents on board with this and maintaining consistency and fidelity to the model is really critical for it to be effective. Behavioral interventions such as applied behavioral analysis are informed by basic and empirically supported learning principles. ABA techniques have been repeatedly shown to have efficacy for specific problem behaviors, such as the one that we're mentioning, like self-injurious behavior and injury to others. ABA has been found to be effective as applied to academic tasks, adaptive learning skills, communication, social skills, and vocational skills as well.
What is the role of medication in treating children with ASD?
The role of medication, there's a role in it, but it's important to keep in mind that there is no medication to treat the core features of ASD. There is no autism medication. It's important to manage parental expectations about medications so that they will often expect a cure or for the symptoms to go away, not just to diminish. Frequent targets for medications can include the comorbid conditions such as ADHD, anxiety, or depression, and other features such as aggression, self-injurious behavior, and hyperactivity and attention, and occasionally psychosis. Both Risperdal and Abilify have FDA approval for the treatment of certain limited conditions within ASD, specifically irritability and aggression. That is, so it doesn't treat autism spectrum disorders. It has been shown in multi-site studies, for example, the RUPP study, to treat specifically those symptoms of irritability and aggression when measured both by clinicians and by parents. So these have become first-line treatments. Generally, these medications are reserved for aggressive children who are putting either themselves or others at risk. They can present with problematic side effects. Parents should know what to look for when these medications are used. Monitoring of medication is quite important.
Could you talk in a bit more detail about these two FDA-approved medications for ASD?
Certainly. Specifically, Risperdal is FDA approved for children between the ages of 5 and 17 with irritability, aggression, self-injury, or mood swings associated with ASD. Adverse effects can include weight gain, dystonia, sedation, very potentially lethal neuroleptic malignant syndrome, as well as tardive dyskinesia, elevations in glucose and cholesterol levels, and elevated prolactin. there's a requirement for laboratory monitoring to include glucose, lipid panel, prolactin levels, abnormal involuntary movement scale, and doses typically start between 0.25 and 0.5 milligrams a day. And effective doses typically, as were found in the rough studies, less than 2 milligrams a day. Although the general FDA recommendations for the use of these medications in other conditions is significantly higher. It's important to readjust down expectations and consider the lower doses. Abilify is the other FDA-approved medication for children between the ages of 6 and 17. It's approved for aggression towards others, intentional self-injury, temper tantrums, and quick mood swings associated with AFD. It has a similar adverse effects as I just mentioned and similar monitoring needs, and it is effective in the doses of 2 to 15 milligrams a day dosing. Again, typically less than is used in other situations.
Are there other medications that are prescribed for ASD patients?
Yes. Stimulants and other ADHD-specific medications should be considered when there is comorbidity with ADHD. It's important to remember that the ASD population may have less benefit from the stimulants than children with conditions such as ADHD without ASD. So they get a response, but it's not as robust. ASD children may also experience more adverse effects, and this is a very important thing to keep in mind. So the response is less robust if the adverse or side effects are more common, including typically insomnia and irritability. The best studied of this group of medications is methylphenidate or Ritalin, doses starting at 2.5 milligrams per dose or 0.125 milligram per kilogram twice or 3 times a day. Many other medications have been used with children with ASD, although there is very little, if any, evidence to suggest that these are effective for ASD.
Is there an indication for medication for anxiety and depression that may accompany ASD?
Yes, there is. The SSRIs may help when there is comorbid anxiety or depression. But again, medications do not help with the core features of ASD and also less robust response and potentially greater side effects. For children, there is more safety data with certain specific SSRIs, Prozac and Zoloft. These also come in liquid, which makes it easier to dispense in small doses. And I mentioned this as a side because I've worked with the compounding pharmacies a lot. They have told me empirically that kids on the autism spectrum often prefer the liquid that's flavored with watermelon, so that's a little pearl. Watermelon flavoring seems to be most preferred by these kids. With ADHD treatment with medications, we're treating kids with autism, also with anxiety or depression. The response rates are lower. We don't expect the same effect as these meds might have for children without autism. Autistic children are also more sensitive to the side effects. Important to remember this. Start with lower doses and look or expect side effects. Possible adverse effects can include here irritability, agitation, sometimes elation, and insomnia.
Great. Thank you so much, Dr. Sherak, for answering our questions today.
You're welcome.
All right, we're going to now switch to the question part of the presentation or conversation. And please type your questions into the question box. Our first question is, are there any particularly effective medication options for the common disorganized sleep patterns found in kids with ASD?
That is a great question because you are absolutely right. These are common patterns. I would say the first thing to do with sleep, and this has been studied, is to really look at sleep hygiene. A number of different medications have been used, and I'm actually pulling out one of my reference manuals from the Academy last year. There was a wonderful day-long symposium on sleep problems, but we know that the use of melatonin can sometimes be helpful, like 5 milligrams at bedtime. Generally, there's a shift away from using sedating antipsychotics like Seroquel. sometimes effectiveness from Remeron, but overall, they recommend starting with improving sleep hygiene, developing routine and a pattern so the child will expect to go to sleep, and so responding to triggers. The medications, unfortunately, provide more of a sedative effect and knock them out, but don't necessarily improve sleep.
Okay, I don't see any other questions at this time. Quite surprising.
But I'm glad that sleep was really brought to the forefront because it is a very typical problem and it's not fully understood, but it is definitely really worth thinking about. And Dr. Judith Owens wrote a wonderful handbook on sleep disorders in children, and I highly recommend that book to everyone. It's really a standout.
Okay, we just got another question. Oh, they're popping in now. Amphetamine versus methylphenidate to start with in kids with autism.
This is a very interesting question to me. I was trained traditionally to start with methylphenidate, go up towards the middle high end of the range, and if no response, that typically 75% of all kids respond to one or another stimulant, and by the time you use both, you've gotten close to 90-95%. One little twist here is the fetal alcohol syndrome question, which can sometimes look like autism spectrum disorders. And Dr. Randy Hagerman, who is a Fragile X syndrome expert, again, something that can also mimic autism spectrum disorders to some extent, has done a lot of work on fetal alcohol syndrome, and she found that kids preferentially who have inattention, as they often do with fetal alcohol, preferentially respond to dexedrine formulations over methylphenidate. So that would include dexedrine or Adderall. So I would still start with methylphenidate, maybe because I'm a creature of habit, but failure to respond to that, I would go on to dexedrine and look. And when I learned that after attending a lecture and talking with Dr. Hagerman afterwards and asking her, I went back into my files and I was following about 10 kids with fetal alcohol syndrome, and I'd started all of them on Ritalin first. And out of the 10, 9 of them were on dexedrine. So, and I'd gotten there. And I hadn't really even thought of that as a common pattern, but she has observed this and wrote about it in her book on neurodevelopmental disorders.
The next question is probably a common one. How do you approach the defensive parent who does not appreciate the physician's concerns?
Well, this is a big question. At the end of my training, like I said, I was interested in autism. Then it was considered a sort of rare condition. I had a 4-hour training by one of the leading West Coast researchers, Ed Ritvo, on how to talk to parents and how to give them the diagnosis. This is a very difficult and sensitive matter, and one that is really best refined over time. Parents, even today, are often very resistant. They may have other ideas about what you should be doing. Partnering with parents requires a great deal of empathy and walking a mile in their shoes, to some extent grieving their loss. They are never going to have a child who reciprocates, who shares in many things. Now, some parents are phenomenal and truly and deeply love their autistic child as much as they love their other children or any child, and they appreciate the child exactly for who the child is, and are very willing and to take on the challenges of dealing with the children and do so with little or no complaints. But not every parent is different, and every set of parents is different. But being with them and sort of finding out where they're at and to work with them is really important. And you know, we refer them to support groups, but they're also very much looking to us for support.
The next question asks, are there some drug interactions between commonly used medications that we should be aware of?
I think the most important things to be aware of with medications in general there's several things. One is the SSRIs can make people irritable and can sometimes trigger what we call sometimes a chemical mania. So kids become irritable, hyperkinetic, they may stop sleeping. Sometimes this is seen in families where there's a predilection for bipolar illness, but not always. That's one thing. These kids can have the so-called paradoxical effect. Cough syrups with dextromethorphan can be disinhibiting and make these kids very aggressive and irritable and keep them up. There are certain dyes, aniline dyes, that, so it's not all old wives' tales. Some kids do have very violent reactions to dyes, and when parents tell you this, and you know, I used to say, oh, it's just, you know, parents talking, but so some kids do become very violent and aggressive when they eat food with certain dyes in them that have specific neurotoxicity. So that's something to look at. Some people notice these children are anxious and they think it might be appropriate to give them the quote-unquote anti-anxiety medications, benzodiazepines, Valium, Klonopin, Ativan. Some children become disinhibited. These medications work in ways and receptors very similar to alcohol, and it's not that unlike people who drink so much alcohol they become punch drunk. So this can happen to these kids, and they will become sort of loopy and disinhibited and aggressive. So it's more about the specific medications, because the biology is essentially the same at play in autistic children and non-autistic children, but the severity of certain reactions to medications may be more pronounced.
What type of therapists or therapeutic interventions do you recommend for children with ASD, especially for those in adolescent years? I have heard that CBT can work well with some youth with ASD.
Well, it's interesting that you would mention that, because I work at a school which is a postdoctoral training site for applied behavioral analysis, and they put out a number of papers over the years, the May School, and it's the school for brain injury, but it's also the school for the more aggressive autistic children that don't go to their autism center site, so they're further down on the spectrum. And I was talking with Dr. Jennifer Silver literally last Thursday about the use of CBT with these children. And again, this is a site where not only do we use ABA, but we teach ABA. So there's a fairly high what's called fidelity to the model there, and tremendous effort to maintain that, which is so critical to ABA. We were talking about CBT, cognitive behavioral therapy there, and Dr. Silver opined to me that when she sees this actual therapy in practice with the lower functioning kids, the emphasis is really, it sort of sorts out more as behavioral. The cognitive part is missing. Now, I have a sort of strange background. I actually trained in cognitive behavioral therapy under a psychologist, because it's not training that psychiatrists usually get, and I used it in a clinic. And I would certainly say higher functioning individuals on the so-called, what we used to call Asperger's, might be able to tolerate the challenges, because CBT for anxiety, for example, say something like elevator phobia, involves facing challenges that are triggering. So you have to have a higher degree of compensatory skills to wrestle with those challenges and to do that. Lower functioning individuals who are, for example, kids who get meltdown in any social context, you want to, as parents, you want to at least be able to take them to a restaurant or something. You shape their behavior and you shape their tolerance through behavioral interventions. And you may reinforce that by talking to them in a repetitive, reassuring manner. And I've seen that done with some of the lower functioning kids. And parents want to they want to be able to socialize. They want to be able to take their kids out like any other parent. But it's not strictly cognitive behavioral therapy in the terms of the words that say like David Barlow or David Cherney have written about in their manuals.
Great, thank you. The next question is asking for some advice. I've had patients who have been diagnosed as having autism by a developmental pediatrician or neurologist, and have also been told that their child has mental retardation or intellectual disability. They are often more upset by being told that as opposed to the autism. Do you have any thoughts on the best way to deal with that?
Well, I think the first way is let's just have a little discussion about what we know about these. And what I learned is that severity of autism is related to IQ, but most kids who are on the autism spectrum, the majority of them are at the lower level of functioning. There are higher functioning individuals who are on the autism spectrum, the so-called Asperger's, and you may recognize them amongst people who become engineers or accountants or who are very involved in computer work. They lack social skills and reciprocity, but they have very powerful cognitive functions that bring them to a level of functionality and success in society that lower functioning individuals don't have. I say several things about, because I work with kids with IQs as low as 30s, is if I could make as much gain in a year as some of these lower functioning kids, I could make half as much a gain, I would be overwhelmed. So having parents rather, learn to appreciate the children that they have and the gains that they make. It's not something that you can lay on them immediately, but to bring them to that point. Like, you know, we're in New England. I grew up in New England. I went and trained in LA. The seasons are very subtle there. When the California poppies came out and bloomed, it wasn't much compared to a single maple tree, but I learned to appreciate it. So, although I missed my New England fall, but having parents deal with the basic rehabilitative model and learning to appreciate the gains that their children can make. One medical ethicist once said that, when does human life begin? That human life begins when you get your PhD from Harvard. So that a very high standard. All of us, are somewhere on the spectrum, and some parents have a hard time accepting the child that they have, whether that child is autistic or not autistic. So empathizing with them, partnering with them, and I think the harder thing maybe is how can you effectively help and continue to work with parents who continue to be angry at their fate and continue to resent the fact that their child is at this functional level and not at a functional level. I've been working in this field. I actually started as a paraprofessional in the special needs classroom 40 years ago. I've been in this field a long time. I like these kids. I like working with these kids. I have to face the fact that not every parent likes or is a good match for every kid, and that certainly applies to kids in the autism spectrum. So you'll have two issues, one with parents who will appreciate you and who work with you and who will come to appreciate and celebrate the gains that their child makes. And then you will have those that will, to a greater or lesser degree, won't. I think the important thing there is how can you continue to be professional and continue to provide services and best serve those parents and children as well.
So the next question I'm sure is on everyone's mind. Access to developmental specialists who can assist in the assessment of an atypically developing child is quite difficult. What suggestions do you have for PCPs to establish an ASD diagnosis if a specialty consultation is not available for 6 to 12 months?
Well, I'd say with some degree of confidence, getting some of these tools that have been developed for use out in the community, the MCHAT, the Modified Checklist for Autism in Toddlers, is one. The American Psychiatric Association also has another one. The DSM5 is very different from the DSM4 and before it, is that it is constructed as a living document, and parts of it that are not there are actually put up online. And so there's an early childhood screen that is available online, and you can download it and look at it and use it as part of your assessment. So that's really important. It's in the book under emerging measures and models, and if you go to the American Psychiatric Association DSM5, emerging measures and models is very important, because the whole point is that these measures are in fact emerging, and we're hoping to bring them into greater emergence. And I was talking about counting symptoms before. What we want to do is, in general, we want to move towards a common practice in which people are using standardized assessment tools, and the language, the common language between parents and clinicians and practitioners and educators is not just the label, the diagnosis, but is more finely nuanced, and it involves the actual assessment and rating skills and rating response on certain skills.
Great. I think that's it for our questions. I want to thank both Dr. Sherak and Dr. Mullare for the lively conversation today. I want to remind people that you will receive a pop-up survey, and we really hope that you'll take a moment to complete that about this presentation. Any further questions for either Dr. Sherak or Dr. Mullare can be emailed to mcpap@beaconhealthoptions.com. The recording of this session will be available on the website sometime tomorrow. And preview of coming attractions. Our next clinical conversation will take place on Tuesday, June 28th at 12:15, and the topic will be assessing risk, preventing youth suicide. Thanks everyone for joining us, and again, thanks to Dr. Sherak and Dr. Mullare.
Thank you.
Bye-bye.
Bye-bye now.